Hello, everybody. Thanks for joining. We might have a couple more trickle in as things get started. But I just wanted to send everybody a quick reminder, just letting everyone know that all of these are recorded. After this lecture series, we will be adding, like trimming them and then uploading them to a website, and they'll be available to view whenever. Once this is ready to go, I will be emailing everybody who has signed up for the lecture, so you'll be able to go back and watch this. But this is our last lecture series of the month, and I want to thank Dr. Erickson for joining us today. She will be presenting, and if there's any questions, feel free to drop them in the chat, and I'll just kind of let her know what the questions are. And then there should be also some time for questions at the end. If you don't feel like asking in the chat, feel free to just pop in and ask a question. Otherwise, we are all good to go if you are, Dr. Erickson.
Yes, yes. Hello, everyone. Thank you for tuning in on a evening in November that is dark and cold, and in Wisconsin it's snowing. So appreciate you being here and being interested in hearing about radiation for pancreas cancer. We'll take, if you have a question, as mentioned, feel free to shout it out. Otherwise, I'm happy to answer questions at the end. And I'm going to get started and just make sure that everyone can see my presentation. Just 1 second here. All right. Is that good?
Yes, we can see it.
Wonderful. All right. So we're going to be talking about radiation therapy for pancreatic cancer. And if you come to Frederick and the Medical College of Wisconsin, you may meet me as one of the radiation oncologists or my two partners, William Hall and Christina Small. We are part of the Pancreas team, and we practice at the Cancer Center. Radiation oncology is above ground where there's windows. We're on the 3rd floor, and we welcome many, many pancreas patients to our department. As you've already come to know, either personally by experiencing treatment for pancreas cancer or as you are learning, if you're a new patient, there's a team that surrounds you. This multidisciplinary team is composed of many different people: surgeons, medical oncologists, radiation oncologists, pathologists, radiologists, various therapists, psychologists, nurses, techs, medical assistants, nurse practitioners, PAs, and these are all people with expertise. We're very blessed at Frederick to have state-of-the-art technology, and we like to practice within the best contemporary practice standards. And we're always interested in evolving innovation, especially in radiation oncology. It's very, very important to have the tools you need to do the very best job. And we'll talk about some of those tools as we go forward. At Frederick and the Medical College, the last treatment is surgery, and we call this a surgery last approach for very, very good reason. For pancreas cancer, chemotherapy is used first in almost all patients, unless a tissue diagnosis has not been made after multiple attempts. Chemotherapy is given to go through the bloodstream and target micrometastatic disease, and also to target where the tumor started in the pancreas and the lymph nodes. And you will go through a number of cycles of chemotherapy. This can last for months. You'll meet us either at the beginning or near the end of chemo, because typically then, after restaging with CT scans, PET scans, MRI scans, radiation is then viewed as the next step. And surgery will then follow radiation, typically about 4 weeks after, if surgery is an option. So what do we need as radiation oncologists to be the most successful in treating you and in getting rid of pancreas cancer? We need to be able to see what we're doing. And that means we need to be able to see the tumor and treat it and all the other tissues that are at risk of harboring cancer cells. But with radiation, we also need to be very, very careful to avoid normal organs that you need for your daily existence, such as the stomach, the duodenum, liver, kidneys, bowel, spinal cord. All of those things are very, very important normal organs that we want to minimize dose to. We need to know when you're on the radiation unit that the radiation is hitting your tumor and the tissues near it that need the radiation during the course of those many weeks. And also, as you're on the table, as you're breathing and you have peristalsis in your abdominal organs, your tumor can move. And we need to be sure that we're hitting it. We also need to be sure that the normal organs haven't moved into a bad position relative to the radiation beams. So this is where we have image-guided radiation, where we use imaging to plan and deliver radiation so that we know what we're doing. We're doing something very important with radiation. We want to make sure we're doing a great job. So the first step after you meet us in consultation, when you come back for radiation planning, is what's called simulation. And that means you're going to come and likely you'll stop at the lab first. You'll get your port accessed or they'll put an IV in your arm. They'll draw some blood work because we need to make sure your kidneys are healthy before we give you intravenous contrast for your planning scan. And we'll have you report to our department. We'll go through the procedure, we'll get a consent signed, and we'll have you drink some oral contrast while we're chatting. We'll move into a room that has a CT scanner in it. That's called a CT simulator. And that has the same size as a CAT scan, but the table is very, very different. You can see the black table in the picture here, very flat, and that's what the table will be like on the linear accelerator that you're treated on. We're going to make sure your port is working or your IV, as we'll be hooking you up to some IV contrast. We'll position you with your arms above your head, either in a mold or if you're on our MR linac, you'll be in a wing board type device that's MR compatible. And we will then begin to scan you. We use 3D and 4D scans without and with contrast so that we can see what we need to see and also assess for the motion of the abdominal organs and your tumor. You'll have a little device on your abdomen that tracks your breathing pattern, and that will be used to help us define how much of a normal margin we need around your tumor so that we can account for the movement. For many patients, we use just CT-based planning, and here are some images that would be typical for most of our pancreas patients. Here's an image on your left without IV contrast. This shows a pancreas tumor that's red and some surrounding normal organs, including the stomach, colon, small bowel, kidneys, liver, and spinal cord. And this is an axial and then a coronal view. And then over on the right here, we have a scan with IV contrast. This is a patient who has involvement of some of the arteries around the pancreas. And we can see that the tumor is trapping those arteries. And we're going to want to target this area with a very, very high dose. As a radiation oncologist, what I do with these images is a lot of work to help create a wonderful plan in that on each slice, I will have to define your tumor, the blood vessels near your tumor, your normal pancreas, and abdominal organs like the duodenum, stomach, colon, and small bowel. We work with another group of individuals called dosimetrists, and their job is to create the radiation plan. So we will come up with a list of goals where we want your tumor to receive a certain dose. We want to limit the dose to your normal organs, and they will put together a plan using very advanced software that tries to meet those competing goals of treating the tumor and sparing the organs at risk that live nearby. Our physicists are also involved in this work. They will check and finesse the plan before you're treated. And then on your first day of treatment, oftentimes they are also at the machine to make sure that things go well. So it's another example of teamwork. We have a small, actually a large army of people who are involved in creating and delivering your treatment. When you get treated on a linear accelerator, you're lying on a table. You can see a patient lying here on that very rigid, straight table. And the linear accelerator will rotate around you and deliver dose at certain positions that are viewed as ideal. And those positions are determined by that planning method. The reason your arms need to be above your head is the linear accelerator wants to treat your abdomen. If your arms were down, your arms could also get irradiated, and we don't want that. For most patients, radiation is daily, 5 days per week, over 3 to 6 weeks, and it's given with low dose chemotherapy, usually once a week. We call that chemoradiation. Excuse me. And most commonly, we use a type of radiation called IMRT. IMRT stands for intensity modulated radiation therapy. And what I mean by that is when you look up at the top of the linear accelerator, as I'm showing you here on this picture with the yellow light coming through, there are a series of leaves that move back and forth to create different shapes. And as the linear accelerator moves around you, that shape will change depending upon the location of the accelerator. Excuse me just a minute. Sorry about that. I've been talking to patients all day, and sometimes I get a little bit of a cough from that. So as that radiation accelerator moves around you and that shape changes, that modulates the radiation beam so that it's hitting mostly tumor and sparing those normal organs that live all the way around the tumor. And that's why it's called intensity modulated radiation therapy, because the intensity of the beam varies depending upon where that linear accelerator is relative to your body. There's another type of radiation that isn't given daily, 5 days a week, that is called SBRT, or stereotactic body radiation therapy. And this is radiation that's given in larger doses per treatment and fewer number of treatments or fractions, usually 5, over 2 to 3 weeks. Typically, this type of radiation is not given with chemotherapy, and it's characterized by giving a very, very high dose to the tumor and a lower dose to the surrounding structures. This is often used when we're doing what we call ablative radiation, where we're giving super high doses if surgery can't be done. But we're also doing it on a clinical trial pre-operatively at lower doses. And some of you may be on our SOFT trial, which I'll talk about in a few minutes, that's comparing giving radiation in those 5 treatments versus 28 treatments over 5.5 weeks. Very important with SBRT to avoid large volumes of the stomach, duodenum, and bowels, because those organs can be injured if the same dose is given to the organ as to the tumor. As a rule, for pancreas cancer, we use image-guided radiation therapy. And what that means is every day that you're coming in for treatment, you're going to get onto the radiation table, and we see here a linear accelerator. This is the table that you'll be laying on. The therapist will position you very carefully. They're going to straighten you. They'll make sure you're lining up with some lasers and with some marks that are on your skin. But the way they really line you up for treatment is by doing either a CT or an MRI scan of you each day before you're treated. That scan is then lined up with your planning scan that we did in the simulator and superimposed. And that helps us check for any big changes in your anatomy that would require a change in the plan. If you're on a CT-based linear accelerator, these images will be CAT scans. And if you're on an MR-based linear accelerator, these scans will be MRI scans. And this is what helps us see what we're doing that I stressed at the beginning was so very important. So doing radiation isn't something that we do in isolation. We are part of a very, very big multidisciplinary cancer team. And every Friday at our tumor board at 6:30 a.m., we are discussing many of the new patients we've seen that week, or patients who have completed certain phases of their treatment where decisions need to be made. And we talk a lot about the sequencing of the surgery, the chemotherapy, and the radiation, and make decisions as you're going through your treatment course that are viewed as the best for you to have the best outcome. We also talk about clinical trials that you're eligible for, and make sure that we want to offer a clinical trial to any patient who would fit into one of the trials that we have so that we can give them the best treatment available. We also talk about some research questions at our tumor board and clinical trial development. So it's a very, very important time for us to be together, focus on our patients, and focus on all of the wonderful treatments that we have to bring to you. So many times we are at Frederick in the medical college using preoperative irradiation. That's the most common type of radiation that we deliver. The goal of preoperative irradiation is to secure the borders for future surgery, such that when your surgeon cuts into the tissues around your tumor, that there's a margin between where the scalpel is cutting and where the tumor is, because we don't want to leave any microscopic cancer cells or visible tumor in the tumor bed when that surgery is completed. We know that this helps the surgeons achieve negative margins and likely decreases the incidence of positive lymph nodes very dramatically. And both of those things improve outcomes, including survival. So our goal is to use everything that we can to help the surgeons do that very successful surgery. We do have some targets when we're treating you. And I talked about, radiation oncologists will use the imaging scans that we get at simulation to help develop your plan. So here you see an axial CT image that has some labels on it. We see what's called a GTV, that's the tumor, and this patient has a pancreatic neck tumor. We have the yellow duodenum, the purple stomach. We have some small bowel and colon. We have a celiac artery here that we're including. And we put a margin around all of that. That margin is called the PTV. That's what we're going to be treating. Here's another slice a little further down where we see a superior mesenteric artery that's often targeted with pancreatic head tumors, superior mesenteric vein, again, the tumor, the duodenum. Here we have some small bowel loops, colon, and again, a margin around unifying all of these called the PTV. That will get the radiation dose. We think about some clinical trials in this preoperative space, and I mentioned the SOFT trial. This is a trial that Dr. William Hall created and that we've had open, and we've accrued a little bit over 80 patients to the SOFT trial. And this is looking at a comparison between that stereotactic body radiation, those 5 treatments, and our standard, which is 5.5 weeks of radiation every day, 28 treatments with chemo. We're examining both the acute and the late toxicities in each arm of the trial, in addition to overall survival, quality of life, and then some imaging changes in the tumor over time. We rarely need to give post-operative radiation here because so many of our patients get pre-operative. The one exception may be if you have what's viewed as a very suspicious mass in the pancreas or in the bile duct or the ampulla, that for some reason, despite multiple attempts at getting a biopsy and proving it's cancer, our GI doctors are not able to do that. Then the surgery is done first to establish the diagnosis, and then chemo and radiation will be given post-operatively. We try to avoid giving a lot of post-operative treatment here because we really feel that the preoperative approach is much better and our outcomes have been much improved doing preoperative radiation and chemo rather than the traditional post-operative. What about definitive irradiation? That's when the tumor is too advanced for surgery or the patient is too frail to tolerate chemo, radiation, and surgery. Typically, in this setting, chemotherapy would be started first for as many cycles as is feasible, and radiation would then follow and be used to treat residual disease in the pancreas and any extrapancreatic extensions or lymph nodes. Typically, definitive irradiation is also given with chemotherapy every week. What we try to do with dose escalated radiation in this setting is give a very high dose to the tumor, which you see here in orange or red, and a lower dose to the surrounding adjacent pancreas and blood vessels. This lets us give that very high dose away from structures that could be injured, like the stomach, colon, duodenum, small bowel, but yet provide an effective dose that essentially can kill the tumor. We use both CT and MRI to define this ablative treatment. And we're very conscious of motion management and daily image guidance in this setting because we want to make sure we're planting that high dose right where the tumor is. As I mentioned, seeing the tumor is very helpful. With IV contrast, oftentimes we can see the tumor on CAT scans, but in about 5 to 14% of pancreatic tumors, they may not be visible on CT. And we also can't use endoscopic ultrasound on the radiation unit, even though that's how the GI doctor often finds the tumor in the pancreas and biopsies it. So what we've found to be very helpful is use of MRI. And we especially do this in the setting of dose escalation. Here you see some images. The normal pancreas looks very, very bright on MRI, but the tumor looks very, very dark. And this lets us separate that normal bright pancreas from dark tumor and give higher doses of radiation to what we've outlined. The MR also helps us see the stomach and duodenum. Here you see the duodenum circled in yellow. We have to be very, very careful in these dose escalation scenarios to really protect the GI structures that are nearby, or you could have issues down the road with bleeding or an ulcer. We call this type of radiation MR guided. So when you come for your CT simulation, you might walk across the hall to the MR simulator. This is an MRI unit that's used for planning purposes and also diagnostic scans. And we would position you in the same position you're in the CT scanner in that mold or wing board, and you would be immobilized very carefully and you'd be scanned, and those images would be coupled with the CT images to help us better define your tumor. This is a workflow that we use when we have MR images. We have a CT image here that I'll use for planning without contrast, one with a T2 weighted MRI, a DWI MRI, and we have post-contrast arterial and venous MRI scans, so that as I'm contouring on one scan, I can see where my contours are on all of those other scans and be very, very accurate with defining your tumor and those other normal structures. We did have an open clinical trial, the MR-guided phase 2 dose escalation for unresectable pancreas cancer. That has been closed, and our preliminary results were presented this fall at a national meeting, and we are working on getting this work published. We really saw some improvement in outcomes in patients who were able to get these higher doses of radiation, and it appeared to be very, very safe. Across the country, there's been a lot of interest in pushing ablative radiation doses very, very high. Memorial Sloan Kettering is one of the institutions that has kind of a three-tiered approach. You would pick which of the 3 dose fractionation schemes you would use based on how close the stomach, duodenum, and small bowel are from the tumor. Our doses on the clinical trial that I just showed you were more in this medium or moderate dose escalation, kind of trying to strike a little bit safer balance between the tumor and the normal tissues. And then there are a variety of other dose fractionation schemes used across the country. The SOFT study is this lower dose. We wouldn't use this for definitive irradiation anymore. We do have our MR linac, and most of our pancreas patients are treated on the MR linac when they come to our department. The Fredericton Medical College was one of only 2 institutions in the United States to have the MR linac starting back in 2018. And now many other institutions have it, but we were able to pilot this so that other institutions could use it. And we find it especially helpful in treating pancreatic patients. We use the MR to plan and guide daily radiation. And we use this for our soft study and for some of our dose escalation patients. The only contraindications to being treated on the MR-Linac are if you're claustrophobic or if you have a pacemaker or any type of electronic device that's implanted in your body that is not MR compatible. And we've had a few patients who've had issues with the width of the bore being a little bit too tight for their body habitus. With the MR-Linac, we can very nicely define and treat pancreatic tumors. You see here beams coming in from all different directions, planting that higher dose right over the tumor while being able to see the stomach, the duodenum, and other important internal organs. And one of the nice things on the MR-Linac is that you can see motion. I'm going to just play this. When you're on the table, we do a cine image this is a patient who's breathing, laying on the table, and the abdominal organs are moving because the diaphragms are moving, but we're able to track that and make sure that our target isn't hopping out of where the radiation beams are focused. This, of course, takes a team of individuals. You'll get to know the therapists very well who treat you every day. They're the people who come and get you from the lobby, walk you back, find out how you're doing. They are our secret spies because if you're not feeling well, they will page us and let us know that you'll need to be seen after your treatment. We have some brilliant physicists and dosimetrists who work here who have really helped to move this technology forward, along with members of the physician team. So it's really, the unit is called the Unity, and the team obviously represents Unity as well. So I have just a few questions that I put up, but I think what I'm going to do instead is stop sharing and take questions that you might have.
So there are a couple questions in the chat. One says, I had 33 days of radiation from Dr. S at Honor Health in Phoenix, Arizona. Dr. Evans said I was not resectable due to the tumor surrounding the superior mesenteric artery. He said that I could lose control of my bowel if he cut a nerve. How can radiation not do the same thing?
Yeah, that's a really good question. The nerves in the body are actually very, very radiation resistant. So we can give very, very high doses of radiation to the perineurium around the superior mesenteric artery and not cause changes in bowel motility in the same way that surgically removing that perineurium would. So the good news is the radiation is safe relative to that. It can cause diarrhea in other ways, and that's why we really try to avoid treating a lot of the small bowel because your small bowel is used to absorb your food. And with some patients, especially when we treat the pelvis, if there's a lot of small bowel in the pelvis, that can cause some malabsorption after radiation, and patients can need chronic Imodium or Lomotil and perhaps a low fiber diet. Not very common in the pancreatic patients, though, to have chronic diarrhea from the radiation.
There's another question that says, if some pancreatic cancer tumors cannot be picked up with a CT scan, should MRI be the best choice?
Not right off the bat. Typically, what happens if a tumor is presenting in the pancreatic head and you can't see it, oftentimes you still see a dilated pancreatic duct and the bile duct may be blocked and you turn yellow. When we see that scenario, even if on CT we can't see a tumor, those are warning signs that a tumor may be lurking. And then the GI doctor would use that ERCP, an endoscopic ultrasound, to see and biopsy the tumor. So that would really be the first step rather than an MRI.
And then there's another one that says, if a patient has received radiation and the tumor reappears, can the area receive radiation again?
Yes, we do that very, very carefully. And we want to make sure that what we're doing is worth the risk. Some patients will recur in the resection bed, the pancreatic bed, even if they've gotten preoperative radiation. And we very, very selectively will re-irradiate that tissue and give a fairly high dose with great care to avoid the GI structures, the small bowel, stomach, if they still have a duodenum, the duodenum. We would do this though only after they've had more systemic therapy and we feel that they do not have any disease outside of that area of recurrence. So this is something that we'll use the MR linac for, and we'll do oftentimes we'll do that 5-fraction approach, very, very tight margins, replanning it each time you're on the unit and being very, very careful.
Thank you. Those are all the questions in the chat so far. So if anybody else has any, oh, there's one new one. This says, are there any restrictions to radiation to pancreatic tumors that have spread to the liver?
Well, typically, if the cancer has spread to the liver, we would use systemic therapy first. Radiation wouldn't be used to treat both the pancreatic primary and the liver lesions up front. If after quite a bit of systemic therapy, there still is visible but much improved disease in the liver and small volume disease in the pancreas, at times we will selectively treat not only the pancreas, but also what remains in the liver. Or if the cancer comes back at a later date in the liver, after chemo, after radiation, after surgery, we can target those liver lesions on their own. And the radiation's actually quite good at that, but it's not the first treatment. Chemo or other systemic therapy would certainly be used for quite a while first.
Thank you. And Michael, you had your hand up, so you can go ahead.
Yes, doctor, are you familiar with histotrypsy? And if so, what is your reaction to that treatment?
Are you talking about where a probe is placed in the pancreatic tumor and kind of dealt with that way with high frequency ultrasound, or what are you
Well,
referring
there's
to?
apparently a new machine that uses high volume ultrasound that destroys the tumor through the almost the bubbling of
Mm-hmm.
the
Yeah.
tissue itself. And I had heard that Freighter's was doing a clinical trial on it. I know
Yeah.
there's one being done in Spain, and there's a few other places, but it's used, as I understand, on the liver uh, quite successfully. There's a doctor in Mission Viejo, California, that's doing quite a bit of it, but there's very little information on pancreas cancer.
Yeah, those other techniques are typically right now, there's ablative therapies for liver lesions that the interventional radiologists will do, where they can use heat or cold, you know, probes to kind of kill the tumor. Radiation works in a different way, but is viewed as uh, sometimes even better than those for actually killing the tumor. In the terms of the pancreas itself, we've really not done much with those types of interventions. They are used across the country. There are centers that will do this very, very selectively. My understanding is that there can be some pretty significant complications relative to the pancreas just because of the very vulnerable structures that are close by. So we haven't developed a program around those modalities to date.
There's another question in the chat that says, when the CT scan report says prominent bile duct, is this a sign that the pancreatic duct may have a problem?
Not always. Some patients can have kind of a chronically dilated common bile duct on their CAT scan that's unrelated to pancreas cancer or other problems. If you see a combination of a dilated pancreatic duct and a dilated common bile duct, that's a double duct sign. That's usually a sign that there's either a bile duct tumor or a pancreatic or ampullary tumor blocking both ducts, and that should be taken very seriously. Then you need to meet a GI doctor and have a ERCP and an EUS and a biopsy.
My apologies, I was driving, so I'm not sure how to raise my hand.
That's fine. I can hear you.
Great. I was wondering with the radiation, if the tumor is involving some major vessels, how do you prevent, I know you try to aim it, but can't the vessels become possibly friable from the radiation?
Yeah, like the nerves, the veins and arteries of the upper abdomen are very, very radiation resistant. So we can give super high doses to those arteries and they remain just fine. They remain intact and doing the good work that they do. So those are structures. Of course, we track the dose to the arteries, but in the ablative setting, they can get very high doses of radiation very safely.
Could I follow up with what determines when to do radiation? I mean, I think you might have covered it a little bit at the beginning. If someone's been having chemotherapy, um, you know, how much chemotherapy before they do radiation?
Yeah. So we typically kind of have pathways, and most individuals, depending upon, we talk about patients having resectable, borderline resectable, locally advanced, or metastatic disease. Most patients with resectable or borderline resectable, and even some with locally advanced type A, will typically get either 8 cycles of FOLFIRINOX or 4 cycles of GemNab. Sometimes we'll switch after 4 cycles of FOLFIRINOX to GemNab, depending upon how the tumor is responding on imaging. And if you have a tumor marker like a CA19-9 or a CEA, if for some reason it doesn't seem that the tumor is responding, switching chemo from one of those regimens to the other can bring about a response. So typically it's that, 4 months of treatment, then you'd have imaging halfway through and then imaging at the end of chemo, making sure there hasn't been anything that's changed unfavorably to allow you to have radiation and surgery. And then you'd go on to radiation. After radiation, you'd have repeat imaging a month later to make sure there are not any surprises, and then surgery would follow. So that's the typical scenario. We don't just keep giving chemo cycle after cycle after cycle. There's really kind of a defined pathway. For metastatic disease, that scenario can be very, very different. And some patients are on chemo or other systemic drugs for years. So that's a whole different paradigm than when surgery is going to be used.
Thank you.
You bet.
There is another question in the chat, and it says, does size and location of the tumor signal whether radiation is appropriate?
Yes. There are patients who we will not irradiate. And that can be for any number of reasons, but one can be size. If a tumor is massive, and it's hard to define what massive means, obviously we're going to want to see what happens first with chemotherapy and other systemic therapy, because we'd like that tumor as small as possible before we irradiate it. If a patient has a very, very large tumor and they're very weak, frail, not eating, not drinking, not able to do normal everyday tasks, we would think very, very carefully about sending radiation in. It may just be way too much for that patient to handle. So size and performance status, and obviously presence of metastatic disease. Those are all things that have to be carefully considered when we're making determination of who gets radiation and how much radiation.
What are the expected side effects of radiation?
So things you might expect that we try to diminish are possible nausea and vomiting. So every day before radiation, we're going to have you take a nausea pill about half an hour before. It can be Zofran, it can be Compazine, Reglan. There are different nausea drugs. And most people won't get sick to their stomach after the treatment if they take the nausea pill prophylactically. The other thing that's very important, both for nausea and for it's not really heartburn. It's kind of a gnawing, empty stomach feeling that you might get near the mid to end days of your radiation. So we want to protect your stomach from your own acid. So we'll have you on some type of acid suppressive medication so that we keep that stomach acid down. And we're going to also have you do more of a bland diet. That means comfort foods, soups, casseroles, things that slide down easily, not a lot of spicy, greasy, or raw foods. That helps you digest your food better and not feel as queasy or uncomfortable after eating. Lastly, fatigue. If you're getting radiation for 5.5 weeks, likely each week you may feel a little bit more tired than the week before. Perhaps not enough to really make you change your routine other than maybe going to bed early, or if you're working, taking a little 20-minute cat nap, put your head down on your desk and get a little bit of a energy surge from that. It's very rare that people are actually right down in bed during their radiation course from the radiation. One thing we have to really be careful of, though, is that you don't get dehydrated. You may not be as hungry during radiation. We're going to encourage you to eat, drink lots of healthy fluids, and try to maintain your weight. That's important because if you lose too much weight, we have to replan the radiation because the radiation is absorbed based on your body mass. So if you lose 10 pounds, that radiation plan looks different than when you were 10 pounds heavier. We will be the weight police while you're under treatment. You get weighed a lot, and we really encourage you, if you're losing weight, to add some nutritional supplements, snack a lot, have that bowl of ice cream that most of us push away or try to push away, just really to get calories in. We may add some IV fluids or some IV medicines if you're struggling, and that's usually near the end of treatment where you might need a little extra help with hydration or getting some steroids to boost your energy and your appetite, those sorts of things.
And then someone asked, could you please explain again the use of the MR linac?
Sure. So modern linear accelerators all have an imaging device inside of them, either a CAT scan or an MRI scanner. And that's so that before you're treated every day, there's a new image of you. It shows, it can show us where your tumor lives and what your normal organs are doing. What location are they in? What may have changed from your radiation planning scan. With the MR linac, those daily images are MRI scans. And what's different about the MR linac than a CT-based linear accelerator is the MR linac has software, a computer, that allows us each time you're on it to adapt the radiation plan. So we can fine tune it each day when you're on the machine. If you were getting just those 5 SBRT treatments, you'd actually be able to have a completely new plan every day you're on the machine. That would require, though, that you're on the unit for about an hour. So it has some wonderful software in addition to the imaging that really lets us fine tune and customize, personalize your radiation treatment each time you're on it.
Thank you. So far, there's no other questions in the chat, but if anybody else has any other questions, feel free to go ahead and unmute yourself.
Hi, I'm wondering about insurance coverage for the different types of radiation, if there is any.
Yeah. So before you're treated, our front office staff sends in for approval from your insurance company. And no matter what type of radiation you're receiving, we have to get that approval because obviously, just like chemotherapy, radiation is expensive. Very, now quite rarely, more in years ago, we'll get some pushback for use of IMRT or SBRT. But more and more, this has been considered the standard of care. We may have to go and kind of do what's called an appeal with your insurance company. They will have somebody call us and have us explain why we want to use the technology that we're using. And most of the time, we get to do what we think is best for our patients. But we don't assume that. We have to check that out with your insurance before you get on the table for your first treatment.
Someone asked, are there any changes to the skin that can occur with radiation?
Typically for pancreatic cancer patients, not a lot of skin changes. If you're a breast cancer patient or a patient with a head and neck cancer or a skin cancer, then you can see that real red, angry skin. but the technology that we have is mostly skin sparing, with the exception that on the MR linac, because of the way that the radiation is absorbed in air-filled loops of bowel, sometimes we'll see a little bit of pink tone to the skin of the abdominal wall or the back, but it's quite minimal, typically not something that bothers you at all. We check for it though every week when you're seeing us for your weekly review. Well, you've been a very attentive and interactive audience. If you're coming to meet us sometime, we welcome you, and I think you'll find that you become quite at home in our department. A lot of people who are on your team wanting you to do well, and we'll work hard to do the very best we can to have you beat pancreas cancer. So it will look forward to meeting you if you're coming our way. If you've already been treated, we wish you well and look forward to seeing you and follow up.
Thank you so much for presenting, Dr. Erickson. All great
You bet.
information. And thank you everybody for your questions. Just a reminder, these are all going to be recorded. And once we have a home for them online somewhere, I will be sending a mass email to everybody who has signed up for these lectures. But otherwise, thank you so much again, everybody, for participating and joining. And everyone have a lovely evening.
You too. Thank you. Bye-bye.